Hello, my name is Robin Perry Mayrand, and I'm a graduate researcher at Florida International University. Today I'll be presenting the computational analysis of a lightweight SUVr processing technique for neuroimaging Alzheimer's disease. I'd also like to acknowledge my co-authors, without whom this work wouldn't have been possible. Christian Yaphet Freytes, Luana Okino Sawada, Micheal Adeyosoye, Dr. Curiel, Dr. Loewenstein, Dr. Duara, and Dr. Adjouadi. In this video, we'll first offer a background on Alzheimer's disease, such as what it is, how it's currently being diagnosed, and the modalities it makes use of. It will then cover the recent topics of neuroimaging research and the issues plaguing it. With a good background, we'll then go over our proposed lightweight processing pipeline that will then be compared to a calibration dataset. The results will then be presented and discussed before going over future steps and final thoughts. Alzheimer's disease is the most common form of dementia and is an incredibly debilitating and irreversible brain disorder affecting millions worldwide. In the United States, it was the 7th leading cause of death in 2020 according to the CDC. While there are no cures for Alzheimer's disease, early diagnosis and treatment can slow its progression and improve quality of life. For this reason, it is essential to recognize the symptoms and seek help as soon as possible. It is critical to understand that Alzheimer's disease diagnosis and research needs a lot of data to provide an accurate diagnosis. On the other hand, while this data is necessary, it can also be very costly and difficult to obtain, and even more so to process for a deeper analysis. Which is why collecting and processing only the necessary modalities is so essential. If we can reduce the amount of data needed, we can make Alzheimer's disease diagnosis and treatment more accessible, affordable, and efficient. And by reducing this data burden, we can also help patients and their families get the care they need faster and more effectively. The gold standard for diagnosing Alzheimer's disease is still a clinical evaluation by one or more healthcare professionals. The clinical evaluation includes a thorough review of the patient's medical history and a detailed assessment of their current symptoms. Moreover, the healthcare professional may also ask the patient and their family about their ability to perform daily activities and other lifestyle habits. The collected information is then analyzed to determine if the patient is exhibiting any of the hallmark signs of Alzheimer's, such as memory loss, language difficulties, and impaired judgment. If these signs are present, the healthcare professionals can then administer a battery of cognitive exams to make a diagnosis and recommend an appropriate treatment plan. While this remains the gold standard for diagnosing Alzheimer's, many other tests and technologies are being developed to supplement the clinical evaluation. For example, blood tests, cerebral spinal fluid analysis, and other biological biomarkers are being used to detect early signs and symptoms of the disease. At the same time, brain imaging and scanning technologies can help diagnose and track the progression of the illness. In recent years, machine learning algorithms have been used to varying success to classify different stages of Alzheimer's disease and against control groups using cognitive exams and neuroimaging data. This development is extremely significant, as it could lead to a better understanding of Alzheimer's and its progression through the cost-effective and automated advantages that machine learning can offer. Neuroimaging technology has revolutionized the way we study the brain. By utilizing magnetic resonance imaging, or MRI, we're able to gain a much more in-depth understanding of the brain structure. MRIs produced detailed images of the brain that can provide us with data far beyond what cognitive exams can. While positron emission tomography, or PET, which consists of injecting a radioactive tracer into the body, allows us to visualize the brain activity. Neuroimaging research can allow us to identify changes in the areas of the brain associated with memory and cognition, as well as detect any abnormalities or damage. For the case of Alzheimer's disease, PET scans are used to observe and quantify different biomarkers associated with the disease. One of the most prominent of these biomarkers being studied is the buildup of amyloid plaque deposits in the brain. The presence of these plaques have long been linked to the onset and worsening of Alzheimer's disease, and researching them can provide important insights into the progression of the disease. When dealing with the large amount of data seen in Alzheimer's disease research, quality control and curation becomes a significant challenge. They are time-consuming and labor-intensive processes, yet absolutely necessary to make sure that the data is accurate and valid. Processing scans also takes a considerable amount of time and computational resources. This can become particularly difficult when dealing with many scans coming from different sources and trying to unify them in a consistent manner. Clinical data can be especially tricky to parse through without having an experienced healthcare professional to review it. This adds an additional layer of complexity to the process and can cause unnecessary delays if not handled properly. All in all, the challenges associated with an Alzheimer's disease neuroimaging processing pipeline can be quite daunting. With proper preparation and a knowledgeable team, they can be managed effectively. The standard uptake value, or SUV, was devised to quantify the PET's pixel intensity value, which represents how much of a radio tracer was absorbed by a brain tissue. This value uses the PET pixel intensity, or C, over a constant B, which is comprised of two pieces of clinical information: the injected radio tracer dose, or ID, and a patient's body weight, or BW. However, in order to further normalize this value across a cohort, it must be divided by a specific reference region, which will then yield an SUV ratio. This SUVr can then be used for PET cohort studies as long as they're from the same radio tracer. But a growing issue was that the development of different tracers, even for the same purpose, will have different binding rates and other unique properties, which made it so that the SUVr of two different tracers were just not comparable. Thankfully, the Global Alzheimer's Association Interactive Network, or GAIN, founded the Centiloid project. It devised a set of SUVr scaling formulas to calibrate all the PET radio tracers for use in cross-cohort studies through the creation of the Centiloid score. As mentioned, optimization is key when dealing with the size and the amount of data. For that reason, we should prune any unnecessary fields or information that can increase complexity. So if we take a look at the SUVr formula, we have that it's the SUV of the region of interest over the SUV of the reference region. We can then just plug in what the SUV formula is, and we have that the SUVr of a region of interest is equal to the PET pixel intensity value of the region of interest over constant B over the PET pixel intensity value of a reference region over constant B. So we can just go ahead and cancel that constant, and we have that the SUVr of a region of interest is equal to the PET pixel intensity value of that region of interest over the PET pixel intensity value of that reference region. So for the purposes of SUVr or Centiloid focused pipelines, we can remove the need to ingest the clinical data needed for the SUV. Now that we have the background necessary to understand the pipeline and the process of the paper, we'll get into the dataset that was used. To evaluate the proposed SUVr lightweight pipeline, the floor beta Ben radio tracer calibration dataset from the Centiloid project was used. This dataset provides the raw DICOM MRI and PET neuroimaging files for 35 subjects, as well as a spreadsheet containing the SUVr and Centiloid score for each of them. The dataset is broken down by age, and we have 10 young, healthy controls and 25 elderly subjects. And it is further broken down as follows. 8 of the subjects are diagnosed with Alzheimer's disease, 2 subjects are diagnosed with frontotemporal dementia, 16 subjects are healthy controls, and 9 subjects are diagnosed with mild cognitive impairment. The first step of the proposed pipeline is preparing a T1 sequenced MRI. The MRI is then segmented into regions of interest, or ROI. This is accomplished with FreeSurfer version 6.0. Following that, the FSL toolbox is used to co-register the PET onto the MRI to make them overlay properly for the next step. Finally, using the segmented ROI, the PET intensity values for each of those ROIs are extracted and the SUVr and Centiloid scores are calculated. As mentioned previously, the SUVr of a region of interest is equal to the PET pixel intensity value of that region over the PET pixel intensity value of a reference region. This pipeline makes use of the whole cerebellum as the reference region. The Centiloid scaling formula for the floor beta-ben radiotracer, or FBB, is as follows. It will then yield a Centiloid score. The results from the pipeline were then compared to those provided by the GAIN calibration dataset. A linear regression analysis was performed. Overall, the data's linear regression had a slope of 0.97. The analysis was broken down into the 2 GAIN suggested group, the elderly and healthy young control. While the elderly subject data has a linear regression slope of 0.95, the young control group has a slope of 0.54. The same method was replicated using the Centiloid value instead of the SUVr, but as expected, since it's only scaling the values, the results are the same. Overall, with a linear regression slope of 0.97, the results do suggest a high agreement between the GAIN provided results and the SUVr lightweight pipelines. However, the linear regression of the young control group might suggest otherwise. This may be in part due to the unbalanced amount of subjects in each group. In that regard, the data was broken down into more balanced groups based on diagnosis. This yielded 16 healthy controls and 19 non-healthy controls. Applying the same method, a linear regression analysis was performed and the healthy control group has a linear regression slope of 0.87, while the not healthy control group had a linear regression slope of 0.96. This time, both subgroups also suggest that the SUVr lightweight pipeline achieved a similar result as the GAIN provided ones. Most of the discrepancies could actually be explained by the selected MRI segmentation software. While the SUVr lightweight employs FreeSurfer, which uses a surface-based morphometry to segment the MRIs, the GAIN pipeline uses the SPM toolbox, which employs a voxel-based morphometry. Their differing methods will lead to a discrepancy in region sizes. Following the conclusion of the study, some improvements and additional branches to investigate were identified. A larger dataset should be used. Additionally, the SUVr lightweight should be evaluated using other radio tracers besides FBB to ensure the consistency of the pipeline. The stability and robustness of different SUVr variables, such as the PET pixel intensity value and reference region used in the SUVr, should be tested. This in turn should provide the most accurate and relevant information for the Alzheimer's disease neuroimaging research community. Thank you so much for listening. We hope you have a wonderful CSCI 2022. We'd also like to thank the CATE, GAIN, the NWSI team, the One Florida ADRC, and Florida International University for their support.